From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. You're listening to the JAMA Author Interviews podcast. Thanks for being here. I am Dr. David Simel, JAMA Associate Editor and Professor Emeritus of Medicine at the Durham Veterans Affairs Medical Center and Duke University. In this podcast, we will be discussing essential thrombocythemia. I'm joined today by Dr. Ayalew Tefferi, who is a professor of medicine in the Division of Hematology at the Mayo Clinic in Rochester, Minnesota. Dr. Tefferi is the lead author of our narrative review on essential thrombocythemia in the January 27th, 2025 edition of JAMA. Thank you for joining us today.
Thank you for having me, Dr. Simel.
Dr. Tefferi, how should a generalist approach the evaluation of a patient after repeating the blood counts and finding that the results are normal except for the high platelet count?
The formal definition of a high platelet count is around 450,000 per microliter or higher. This is at the higher end of the reference range for the normal population, which is between 150 and 450,000 per microliter. This threshold is also used by the International Consensus Classification System as one of the major criteria to diagnose essential thrombocythemia. So when a physician encounters such a platelet count, first thing they need to remember is that more than 80% of the time, this is going to be a secondary phenomenon and does not necessarily represent a primary bone marrow disease, such as a hematologic neoplasm. Therefore, it's important to look at the clinical scenario and see if there are any conditions that might be associated with secondary thrombocytosis, such as infections, autoimmune diseases, inflammatory disorders of any kind, iron deficiency anemia, history of splenectomy, recent surgery, and sometimes metastatic cancer, including lung cancer.
Well, once a physician has ruled out secondary causes of the thrombocytosis, they're left with deciding whether or not the patient has a hematologic disorder. What is the case definition of essential thrombocythemia?
The essential thrombocythemia is formally defined by the International Consensus Classification System, where it has partnered with many other conditions under the umbrella term of myeloproliferative neoplasms, and they include, in addition to essential thrombocythemia, polycythemia vera, and myelofibrosis. The criteria, the formal criteria, include a platelet count to be at least 450,000 per microliter. But in addition, they would like to see a bone marrow morphological examination that shows megakaryocyte proliferation, mostly of mature forms, and then that we have to exclude other myeloid neoplasms, such as chronic myeloid leukemia or polycythemia vera. And then finally, it is advised that we do mutation screening tests to see whether they have the characteristic JAK2 CALR MUPL mutations. But we have to remember that in about 10% of the patients, those mutations might not be present, and it could still be essential thrombocythemia.
Before I ask you a little more about those mutations, let's get back to the question of a bone marrow. You mentioned in the differential diagnosis polycythemia rubra vera, which would be characterized by a high red cell mass, and then chronic myelogenous leukemia, which would show abnormalities in a white blood cell count. If you don't have either of those, is a bone marrow aspirate still required to make the diagnosis of essential thrombocythemia?
It depends on the expertise of the physician assessing the situation. For example, if the physician is very well versed with these diseases, they can look at the peripheral blood smear and look at changes there that might make them suspect something else. Let me explain a little better here. In patients with myeloproliferative neoplasms, those who present with essential thrombocythemia usually have a rather underwhelming peripheral blood smear that only shows a lot of platelets. In other words, they don't have anemia, they don't have any circulating immature cells, and the serum chemistry shows a normal LDH, which is lactate dehydrogenase. And these things can be looked at together with a clinical presentation of a patient who may not have a palpable spleen. They are otherwise asymptomatic. So then one can make a suggestion, make a working diagnosis, and therefore does not necessarily require a bone marrow examination to suggest, well, this is my working diagnosis. I'm not suspecting CML or prefibrotic myelofibrosis, so I will follow the patient because doing a bone marrow examination is not going to change my management plan. So depending on the expertise of the physician who's assessing the patient, one can make a working diagnosis without the need to do a bone marrow examination. On the other hand, experts feel that it might not be a bad thing to have a baseline information that is complete, meaning have a bone marrow examination, chromosome studies, and all the gene studies, since these patients will be expected to live a very long life. So it will be nice to have a baseline in case something happens, and that could be used as a comparator.
Tell me a little bit more about the mutations.
These three mutations that I mentioned, the JAK2, CALR, and MPL or MUPL mutations, all of them are gain-of-function mutations that activate the JAK-STAT pathway. And that appears to be the common pathway that is activated in these myeloproliferative neoplasms. And interestingly, they are quite specific, although not 100%, to these myeloproliferative neoplasms, but they cannot distinguish one from the other. All patients with polycythemia vera, for example, are expected to have a JAK2 mutation, all of them. So if you don't have a JAK2 mutation, that's not polycythemia vera. On the other hand, the other two, including essential thrombocythemia, usually have about 60% JAK2 mutation, but in 40% of the patients, the mutations are other than JAK2, which include the CALR mutation, approximately about 20 to 25%, and the MPL mutation, approximately 3 to 5%. So these are very useful diagnostically, but also these mutations have, since they've been described in 2005, have actually led to the research and development of new drugs that target these mutations and therefore potentially treat these patients.
In your review, you noted that about 10% of patients don't have any of those mutations.
That is correct. And we usually refer to those patients as being triple negative. They are usually very similar in their clinical presentation with a few exceptions. For example, those patients usually might have a higher platelet count than usual. They might have usually a lower incidence of complications over time. The triple negative essential thrombocythemia is considered to be the favorable type of essential thrombocythemia, even though all of them are favorable, but they seem to have a lower risk of thrombosis, a lower risk of transformation into myelofibrosis or leukemia. Some argue that perhaps some of these patients might not really be essential thrombocythemia, that they could be yet a secondary phenomenon of unknown origin. But in general, it really doesn't matter. The patient is managed as triple negative, and they probably have a very favorable prognosis.
Well, most patients are going to be asymptomatic at the time of diagnosis. It's just something we find incidentally on a complete blood count. But not everyone is asymptomatic. Could you review for us for some of the symptoms that a high platelet count might be associated with?
Yes. I usually look at symptoms of essential thrombocythemia in two classes. One would be life-threatening symptoms, and this includes thrombosis and hemorrhage. And the other ones, I generally refer to them as being non-life-threatening, even though they're quite annoying when you have them. And this includes microvascular symptoms, which is an umbrella term that includes migraine headaches, for example, lightheadedness, painful sensation of the fingers and toes, atypical angina-like chest discomforts, and some patients, about 10%, might have palpable splenomegaly. Now, these symptoms occur in around a third of the patients when they present with their disease, and usually do not portend any more serious complications that are forthcoming. But the life-threatening ones, thrombosis and hemorrhage, that might occur in about 10 to 20% of patients, either at diagnosis or after diagnosis, are actually the real reason why we treat these patients with essential thrombocythemia.
So a patient may be asymptomatic or they may have symptoms. In thinking about the driver mutations that you mentioned, is that something that a generalist should order on the peripheral blood, or is that the time to request a hematologist consultation?
Actually, I am in the minority when I say that essential thrombocythemia is really an internist's disease. These are not very difficult tests. They're widely available. When the internist looks at the patient with essential thrombocythemia, I think they're the best ones to make sure that this is indeed a primary condition and not a secondary condition. And once they rule out the possibility of a secondary process, they can simply order peripheral blood mutation screening. The mutations are the same whether you look for them in the peripheral blood or the bone marrow. So you can just order mutation screening for JAK2, CALR, and MUPL and expect to be positive in 90% of the times if this is indeed essential thrombocythemia. But the generalist should consider the possibility that all that it tells you is that there is an underlying myeloproliferative neoplasm, but not specifically ET. So when these mutations are present, they don't necessarily mean that it is one or the other. It just means that it is an underlying myeloproliferative neoplasm, and you have then to consider all the other presenting symptoms in order to make a specific diagnosis.
In your review, you specifically mentioned the association of thrombosis in the splanchnic vein distribution or the cerebral vein as possibly indicative of a myeloproliferative disorder. Can you tell us a little bit about that?
Yes, these are very interesting phenomena that we see with patients with myeloproliferative neoplasms. They're very infrequent. For example, in essential thrombocythemia, the prevalence or the incidence of a large abdominal vein thrombosis is probably around 5%, and cerebral sinus is much less, and less than 2%. But when they happen, and they usually happen in younger patients in preference to the female gender as opposed to the male gender. And when it happens, it's so unusual that one has to consider myeloproliferative neoplasms because it's not frequent that the general population gets this as part of the cardiovascular risk in the general population. So they're rare, but when they happen, then they tell you that probably you're dealing with a disease, an underlying disease, which increases the risk of thrombosis, especially site-specific thrombosis. And this appears to be very much related to the JAK2 mutation.
Well, let's think about the asymptomatic patient who you've requested the mutations on, found that they're positive, and you think you have a diagnosis of essential thrombocythemia. You told us that the prognosis is good. How good is good, and what is their risk of developing thrombosis?
The prognosis in patients with ET, I usually compartmentalize it into two categories. One is survival. Survival is excellent. Patients who are below age 50 can expect to live much higher than 3 decades. And even older patients can expect a long-term survival, but obviously they're not going to live longer than they're supposed to live, even without the disease. So it is an excellent prognosis, almost near normal life expectancy. The only reason why it's not normal life expectancy is because over time, there is a residual risk of transformation into myelofibrosis, which is about 10% over the first 20 years since diagnosis, and about 5% for acute leukemia. So these are very rare, infrequent occurrences, but they do occur. And as a result, they compromise the lifespan of the patient who has this disease. The second category of risk would be thrombosis. Now, mind you, when we say excellent prognosis in survival, which means that we're not treating patients with ET to prolong their life because that's already prolonged, and nobody has shown that doing anything is going to prolong that further or prevent the complications of leukemia or myelofibrosis. Therefore, the treatment in patients with ET is usually to reduce the other risk, the other major risk, which is thrombosis. In that instance, the most important risk factor for thrombosis is the occurrence or the presentation with thrombosis. So if somebody has a history of thrombosis, they are at the greatest risk of getting a recurrent thrombosis. Other than that, there are some additional contributors to thrombosis, and this includes the JAK2 mutation, which definitely is associated, as opposed to the other mutations that might be associated with essential thrombocythemia. Patients with the JAK2 mutations have a higher risk of thrombosis. And obviously, older age is always associated with increased risk of thrombosis, even in the general population. Whether or not it is really that much higher in patients with ET as a result of the disease itself is not very clear. But in general, the JAK2 mutation and a history of thrombosis are the two factors we look at.
When you say older age is obviously on a continuum. In general, what are you thinking of for risk stratification on age?
In the clinic, when I see my patients, I look at their biological age. In other words, I see how they are and so forth, and what their lifestyle is, exercise program, everything. And for them, I put the age up to 70 as I consider older age, meaning where I would intervene with something that is indicated for older age. On the other hand, others are frail, they have other issues like cardiovascular disease, diabetic, hypertension, and in those instances, then I usually consider older at about age 60.
So what are your treatment decisions, and how does risk stratification for thrombosis play in?
They do very well without any treatment, and the only thing that worries me would be that thrombosis risk. And for that, as I have mentioned before, I look at the thrombosis history, the presence of JAK2 mutation, and the age, and I combine all three. And if the patient is below, say, age 60, they don't have a history of thrombosis, and they don't have the JAK2 mutation, I consider those patients either very low risk, and usually those patients can be managed with one baby aspirin a day. If they have a JAK2 mutation, but they're still young and don't have a history of thrombosis, then I usually give aspirin twice daily because there are studies now suggesting that the property of aspirin as a treatment is best utilized. In other words, the 24-hour sustenance of activity is best accommodated by having the drug taken twice a day rather than once a day. And that might be true for the general population as well. But otherwise, if they are above age 60 years and have a JAK2 mutation, have a history of thrombosis, then those are the patients that I would be a little more aggressive. In other words, in addition to one baby aspirin a day, I might give them cytoreductive therapy in the form of hydroxyurea or interferon in order to minimize the risk of thrombosis. The data are not very hard. Controlled studies are very scarce in this disease. Therefore, most of it is based on personal experience and retrospective studies. And usually, higher risk patients in general need to be treated with not only aspirin, but perhaps with addition of cytoreductive therapy.
Some patients can be asymptomatic yet have extremely high platelet counts, like over 1 million. Does the platelet count number itself affect your treatment decisions?
I'm glad you asked that, Dr. Simel. We call these patients as platelet millionaires. Now, in general, the high-risk patients, meaning patients with history of thrombosis, they're already on some cytoreductive therapy, so we usually don't see the extreme thrombocytosis. But the patients that are not high risk and low risk, young and no history of thrombosis, especially if they have the CALR mutation or the triple negative mutational status, can have a platelet count of over 1 million. In general, about 20% of patients present with a platelet count of over 1 million. And some actually might have over 2 million, less than 2% perhaps. And these patients, what we have seen over and over again is that the very high platelet count is not necessarily indicative of a higher risk of thrombosis. In fact, if anything, it's indicative of a higher risk of bleeding and not thrombosis. And therefore, we don't usually treat the platelet count. We treat the patient in that we look at other risk factors. But otherwise, if you are a platelet millionaire, the only thing I would worry about is bleeding. And therefore, I'll make sure that the aspirin therapy that I give you, first of all, I would not give you twice a day aspirin. I will only give you once a day aspirin. And then I watch for any clinical signs of bleeding so that I will hold the aspirin if you have some excessive bleeding.
Young people can get essential thrombocythemia, including during the childbearing years. How does ET affect pregnancy outcomes?
Well, we have to remember that ET is actually a disease of young females. The median age of ET is about 59 years, and females represent about 64%. If you think about it, about 18% of patients with ET present below age 40 years. And of those, 70% are females. So therefore, it is an important scenario that needs to be addressed. And the problems with pregnancy with ET, first of all, most of them are successful with no problems. So it is not a contraindication to being pregnant. There is an increased risk of first trimester miscarriage, about 20 to 25%. And fortunately, the use of one baby aspirin a day before pregnancy and throughout pregnancy has been shown to help in that regard. It almost brings it down to 10 to 15%. Other risk factors like maternal complications, stillbirth, preterm birth, they're very unusual, including some maternal complications such as preeclampsia, thrombosis, major bleeding. Those are all uncommon. They need to be looked for, but they are usually uncommon. So in general, when I have a patient with ET, I will tell the patient that their platelet counts probably will decrease in the second and third trimester, because that's a physiological occurrence with ET, and that I want to make sure that they're put on baby aspirin before and after, but otherwise I'll tell them that they're going to be fine. Now, obviously, if they are a higher risk to begin with, if there is a young woman with a history of thrombosis, that they would have been put on some sort of treatment, and there I want to make sure that they stay away from drugs that could be teratogenic, and so we usually use interferon-based therapies and avoid treatments such as hydroxyurea or anagrelite in this scenario.
Well, thank you, Dr. Tefferi, for joining us today to talk about essential thrombocythemia. I am Dr. David Simel. You can find a link to the article in this episode's description. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcast. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.